In terms of sexual activity, after the lab ban or the banning procedure, you can resume sexual activities within 14 days. With the gastric bypass or the Fobi pouch, we normally recommend 30 days. And then with the bilipancreatic diversion, it's normally 6 weeks. What is interesting about weight loss surgery is that people who are overweight develop a certain amount of infertility. Losing weight increases the fertility because it takes away the fat around the ovaries and the tubes where the eggs are formed. And so as you lose weight, your fertility goes up. So we recommend to patients who have weight loss surgery to practice what I'll call take medications to prevent pregnancy for at least 12 to 18 months so they don't get pregnant, because the fertility goes up, particularly during the first 6 months when you lose rapid weight. That happens the same with all the operations. What is interesting about bariatric surgery is that when we started doing it, we did the procedures. Most of the bariatric procedures evolved from observing complications from other surgical procedures. So we adapted the procedures and we did them. We are just beginning to understand the physiology of the operations we do. For instance, in the Fobi pouch and the gastric bypass, we are now understanding that there are hormones that are released by the body by bypassing part of the stomach and the duodenum that controls the appetite center. And the way I look at it, and I talk about this all the time, I see in 10 to 15 years that a medication would be developed to do exactly what the surgery does once we understand how the surgery works. We are beginning to get a good understanding, and there are more academic centers now that are doing bariatric surgery and studying the hormonal effects. And this is going to go the same way as ulcer surgery went. For those who are old enough to know, when people used to have ulcers, we used to do ulcer surgery by cutting their stomach. And that's how we found out about weight loss surgery. Now we give medications for people with ulcers because we finally found out how the ulcer surgery worked, and we were able to develop medications to do what they do. So my prognosis is that 20 years from today, there will be very few bariatric operations done, and most of the obese will be treated with a medication that would mimic what the surgery does. But in the next 5 to 10 years, the number of people having bariatric surgery is going to keep increasing. As I stated before, only 2% of those who qualify are able to have surgery. I anticipate that by 2013, we'll be doing about 1 million bariatric operations a year from the 200,000 we're doing today. Immediately after all of these operations, we recommend that you don't eat solid foods for 2 reasons. One, you can form a blockage because the pouch in all these operations is made to be small. And if you eat any solid food and you don't chew it well, it might block, or you might end up with you vomiting it. Number 2, in operations where the stomach is cut, like in the gastric bypass or Fobi pouch, if you eat solid foods and it causes a lot of pressure, it can rupture the pouch. So in all these operations, we recommend that in the first 3 to 6 weeks, you stay on puree diet. That means all the food you eat has to be ground so that it's like baby food, and then you can eat it. Patients come and complain about vomiting. There are 2 things about this surgery that patients have to understand. There is what we call vomiting, which means bringing out a lot of food that you've eaten. And there is what we call an overflow of regurgitation. That means part of the food that you took came up. Okay, there are 2 different things. It's like a funnel. If you fill it up too full, there's an overflow. That's called regurgitation. Vomiting is when everything you ate comes back. So most of the patients don't have vomiting, they have regurgitation right after the surgery. That means they're putting more into that stomach that it can hold. And so the excess flows out. In the meantime, they're getting some nutrition. So we explain that to the patients by showing them in the office how the funnel works. By pouring liquid and showing them the overflow, And the fact that even though there's an overflow, some of the liquid is still going through the whole of the funnel. And by making these demonstrations, patients understand that they have to eat slowly and chew their food well, not eat and drink at the same time, eat and then drink later, so that they don't have this problem with overflow. It's producing stomach acid, but less. Only the small amount that is produced. That is one of the reasons you lose weight, because some of the food that you eat does not get digested because it doesn't have the acid to digest it. So some of the food goes through you undigested and therefore doesn't get absorbed to your body. And those are some of the advantages of having the surgery. The stomach is like the vagina in a woman. When she uses it, it works. She can go for 10 years without using it, it is still there. And then she can come back and start using it, and with a couple of uses, it comes back to normal function. So it's a reservoir. It's similar to the reservoir of the vagina. It has the same type of organs, the same type of mucosa. It works as long as you use it. If you don't use it, it does not completely shrivel away. It just decreases its amount of secretion. The biggest finding we now have in bariatric surgery is that we are able to cure type 2 diabetes. Those of us in the field, I wrote about this back in 1983, that weight loss surgery might become the cure, but that has become accepted now. That is why the society, which used to be the American Society for Bariatric Surgery, has changed its name to the American Society for Metabolic and Bariatric Surgery, because the weight loss surgeries we're doing now is turning out to be a cure for type 2 diabetes. And it works in two ways. The weight loss cures the diabetes. But we also find out that in the gastric bypass procedure, in the Fobi pouch procedure, where part of the stomach and the small bowel is bypassed, by bypassing that part of the stomach and small bowel, the body is releasing an endocrine substance that makes the insulin work better. And so patients who come into the hospital with diabetes have their blood sugar controlled 2 days after they leave the hospital, after they've had the gastric bypass or the Fobi pouch. That is why I stated that as we learn and understand more how these surgeries work, we might be able to develop a pill that mimics what the surgery does. But this is the biggest advantage of bariatric surgery at this time. That is why it's getting more accepted. Bariatric surgery now is turning out to be the cure for type 2 diabetes. With gastric bypass or the lap band or any of the operations we do, some patients are not going to succeed, or they would have complications. If we have to reoperate on these patients, that is called revision surgery. Revision surgery means that we're going to revise the surgery that was done. Sometimes we revise the lap band to the gastric bypass, or the gastric bypass to a sleeve gastrectomy or to a biliopatrectomy diversion. If a patient has a complication, then we'll have to go and revise the procedure to make sure it works. In my hands, about 5% of patients who have this surgery will need a revision within the first 10 years. With different procedures, the revision rates differ. With the Fobi pouch, the revision rate is 5 to 6%. With the gastric bypass, the revision rate in 10 years is anywhere from 5 to 30%. With the lap band, the revision rate in 5 to 10 years is more like 10 to 40%. So that is information that we'll give the patients. Some of the operations have higher revision rates than others. Revisions have higher complications than the primary operation, because when you go to revise, you're going to work in an area where work has been done. So the chances of leaks, infection, and bleeding are higher. So we don't like doing revisions except we really have to. Well, I just got the award for the most Outstanding Achievement Award given by the ASMBS Foundation, which was handed to me in Dallas on June the 25th, in Dallas. I'm very proud of getting that award. There are only 10 other bariatric surgeons who've gotten that award in the past. It's an award that's given by your colleagues, your experts in the field, to say they recognize your work in the field. And so I'm proud of it. I've received many other awards from various places. My travels overseas, I got awards when I was in Brazil, from Mexico, from Venezuela, and from Chile, and other countries where I've been to. But this meant a lot to me because it came from my colleagues, American surgeons, who said, yes, Mal, we appreciate your contribution to the field. And for this year, you have the Outstanding Award. On the other hand, I look at it as a Life Achievement Award. That means it's time for me to quit.